بسم الله الرحمن الرحيم. أعزائي طلبة المرحلة الرابعة، السلام عليكم. We continue with you the management of diabetes mellitus, and today we will discuss the pharmacological treatment of diabetes mellitus. And by this I mean the use of anti-diabetic agents in the treatment of diabetes mellitus. And to start with, the first anti-diabetic agent that we will discuss is insulin. And you have many insulin types. These types of insulin differ in their onset of action, and the time of peak of activity, and the duration of action. According to these three important parameters, we may have a rapid-acting insulin. And this insulin analogs such as Lizobro and Aspart. Such insulin works in 15 minutes, peaks between 30 to 90 minutes, and lasts for 3 to 5 hours. And because of this rapid onset of action of this insulin, it can be given just before or after meals. The second type of insulin is short-acting insulin, like soluble insulin. Such insulin works in 30 to 60 minutes, peaks in 1 to 4 hours, and lasts for 4 to 8 hours. It is taken 30 to 60 minutes before meal. The third type of insulin is intermediate-acting insulin. An example for that is isoquine and PH, Lenti. Such insulin works within 1 to 3 hours and peaks in 3 to 8 hours and lasts for 7 to 14 hours. It can be used overnight because of this long duration of action. It can be given or used overnight. The fourth insulin is long-acting insulin. An example for that, bovine ultra lenti. Such insulin works in 2 to 4 hours, peaks in 6 to 12 hours, and lasts for 12 to 30 hours. Also, it can be used overnight. Long-acting insulin analogs, such as Lantus, or between two brachysargine, Levemir, which is Detemir. Such insulin works in 1 to 2 hours, lasts for 18 to 24 hours with no peak. Now, how do you know the recommended dose of insulin? How could we calculate the recommended dose for insulin for diabetic patients? Really, calculating insulin doses is still empirical. We don't have fixed rules to calculate the insulin dose. However, for type 1 diabetes mellitus, such dose may vary between 0.4 to 1 microgram per kg per day. And for type 2 diabetes mellitus, it varies between 0.2 to 1.5 microgram per kg per day, according or depending on weight, glycemic state, severity of insulin resistance. After we calculate the dose or recommended dose of insulin, we should choose the way of administration of insulin, how frequent we give this insulin for the patient. So the type of insulin therapy depends on, first, the desired glycemic control, whether we have severe or less severe hyperglycemia. The second important factor on which we may depend in choosing the type of insulin therapy is the severity of insulin deficiency, whether we have severe insulin deficiency, moderate insulin deficiency, absolute insulin deficiency, and so on. And the third factor is the patient's ability to adjust the insulin dose. According to these three parameters or factors, we may choose the type of insulin therapy. However, most people require 2 or more injections of insulin daily. The first type of insulin therapy is the standard insulin therapy. And in this type of insulin therapy, 1 to 2 injections per day using intermediate or long-acting insulin with or without short or rapid-acting insulin. Such standard insulin therapy seems to be simple, relatively safe, and convenient to the patient. The second type of insulin therapy is the basal bolus therapy. And in this type of insulin therapy, the patient usually is given 3 injections of soluble insulin or rapidly acting insulin, together with twice daily NPH, or sometimes if we use glargine, we may give it once a day with these 3 times daily injection of soluble or regular insulin. Such type of insulin therapy is used for type 1 diabetes mellitus. The third type of insulin therapy is to have mixed rapid acting and intermediate acting insulin. This is called the premixed insulins. And such premixed insulins, we have many types. It is either mixture of NPH or isofen 70% plus 30% regular or rapid acting insulin. This is called 70-30. Or sometimes the mixed or premixed insulin is composed of 75% neutral protamine lisibro plus 25% lisibro or aspart. Or sometimes the premixed insulin is composed of 50% isofen or NPH and 50% regular insulin or short or rapid acting insulin. Such premixed insulins are usually administered twice daily, 10 to 30 minutes before eating. The fourth type of insulin therapy is what is called once daily injection or injections. Rarely such type of insulin therapy achieves satisfactory glycemic control, but it seems to be appropriate for elderly patients. It seems to be appropriate for some patients who retain substantial endogenous insulin secretion. The other type of insulin therapy is insulin in combination with oral anti-diabetic agents. And such modality or such type of insulin therapy is used for treatment of type 2 diabetes mellitus. Whenever we have failure to control the blood sugar by the conventional measures or combination of oral anti-hyperglycemic agents. The other type of insulin therapy is what is called bedtime insulin and daytime sulfonylurea. Also, such modality or such type of insulin therapy is used for type 2 diabetes mellitus. In gestational diabetes, when proper diet and exercise fail to achieve acceptable blood glucose, the treatment is by insulin therapy. An important phenomenon that we used to face among diabetic patients is elevation of fasting plasma glucose. In other words, fasting hyperglycemia. And fasting hyperglycemia may be the outcome of one of the 2 mechanisms. In the first instance, we have what is called smoggy effect. And in this, there is rebound hyperglycemia that follows undetected nocturnal hypoglycemia in the early hours of the morning. The time of occurrence of this hypoglycemia may be in the 2 to 3 a.m. during night. So, because of such hypoglycemia, there will be a release of counter-regulatory hormones that may contribute to the increase in the blood glucose in the early hours of the morning. Such effect is treated by decreasing the preceding evening dose of insulin, or by changing the time of administration, say from pre-dinner to bedtime. The other phenomena that may contribute to elevation of fasting blood glucose or fasting hyperglycemia is what is called dawn phenomena. In this phenomena, the nocturnal secretion of growth hormone is responsible for nighttime to morning rise in the blood glucose. This condition is treated by increasing the evening dose of insulin, or by altering the timing of its administration, or by changing the type of insulin. And as you see, although both phenomena are characterized by fasting hyperglycemia, the mechanism of each is different, and the treatment of each is quite different. And it is very important to know which is which. And the key to the diagnosis of the possible cause of fasting hyperglycemia is to check for the blood glucose at 2 to 4 a.m. time at night or during sleep. If the blood glucose at this time is low, or if there is hypoglycemia, then the phenomena is in favor of Samungi effect, and for which the treatment should be avoided. If the blood sugar during this time is high, or there is hyperglycemia, so this is in favor of what is called dawn phenomena, and should be treated accordingly. So it is of utmost importance to know which is which, because the treatment is different in Smoogie from that in dawn phenomena. Now, the other entity of antidiabetic agents is what is called non-insulin agents. And in this group, we have two main groups. We have two main agents. The main one is, or the first one, is insulin secretagogue, such as sulfonylureas, meglitinides, and so on. They have similar mechanism of action. All these sulfonylureas have similar mechanisms of action and may cause hypoglycemia. That's why they are called hypoglycemic agents. The other group of antidiabetic agents is a group that includes anti-hyperglycemic agents which are not hypoglycemic agents. These classes of non-insulin agents target a different pathological process. An example for that is metformin. Here, it is just to show you the sites of action of antidiabetic drugs or agents. In the liver, we have the metformin and thiazolidinediones that affect gluconeogenesis and decrease glucose output from the liver to the circulation. On the pancreas, we have drugs that increase insulin secretion, such as sulfonylureas, meglitinides, and incretin-based therapies or agents. And here on the muscles and adipose tissue, we have antidiabetic agents that increase peripheral glucose uptake, like metformin, like thiazolidinediones, and of course insulin, increase insulin sensitivity through this thiazolidinediones. And you have some of antidiabetic agents that delay absorption of glucose from the gut or the bowel. An example for that is alpha-glucosidase inhibitors. Now, we should have short notes about these anti-diabetic agents. To start with, we will discuss sulfonylureas. The mechanism of action of this is through increase in the beta cell sensitivity to glucose and accordingly increased secretion of insulin. Also, they contribute to the reduction or decrease in the insulin resistance. Although these antidiabetic agents, which are the sulfonylureas, have the same mechanism of actions, but they differ in many aspects. They differ in their potency. They differ in the time of onset, in the duration of action, plasma protein binding, absorption characteristics, and route of metabolism and excretion. Such sulfonylureas are generally appropriate for patients older than 40 years of age at the time of diagnosis of diabetes. They are appropriate also whenever the disease duration is less than 5 years. Also, they are appropriate whenever we have diabetic patients with lack of obesity. It means non-obese diabetic patients. And also whenever the fasting blood or plasma glucose is less than 300 milligrams per deciliter, sulfonylureas seems to be appropriate for treatment. Keep in your mind that these sulfonylureas may have a primary failure rate in the range of 20 to 25%. Also, after use of these sulfonylureas, the patient may have what is called secondary failure rate, which falls between 10 to 15% per year. And this secondary failure rate might be due to progressive beta cell failure or a progressive increase in insulin resistance, or sometimes it might be due to decreased patient compliance. Examples for sulfonylureas, although they are classified into first generation, second generation, third generation, but the commonly used sulfonylureas in the daily medical practice are like chlorobropamide, tolubutamide, glibenclamide, gliclazide, glipizide, and glamberide. The other group of antidiabetic agents is the group of biguanides. Example for biguanides is metformin. Another example is fenformin. But the most commonly used biguanide is metformin. What's the mechanism of action of metformin? The major mechanism of action of this drug is by inhibiting gluconeogenesis. So it decreases glucose outpouring from the liver to the circulation. Also, metformin enhances glucose uptake and utilization by muscles. Metformin also decreases the intestinal absorption of glucose. And because metformin may cause weight loss, so it is preferred for use in obese diabetic patients. Also, metformin is used in patients with impaired glucose tolerance and metabolic syndrome. And the use of metformin in these two conditions is a prophylactic one. It is used as a prophylactic measure against development of diabetes. However, with metformin, the patient may have primary failure rate of 12%. Secondary failure rate also might be detected or recognized with metformin use in the range of between 5% to 10%. The side or the common side effects of metformins are the gastrointestinal side effects. And these include metallic taste, anorexia, nausea, abdominal discomfort, diarrhea, and so on. Usually these gastrointestinal side effects are transient and mild and can be improved by reduction in the dose of metformin or by giving such medicine with food or with meals. So these side effects are not indication to stop metformin. A more serious side effect, which is a metabolic side effect of pegonize, particularly fenformin, is lactic acid or lactic acidosis. It is a type of metabolic acidosis. And such lactic acidosis occurs most often in diabetic patients with renal disease or with low cardiac output, in other words, in heart failure, or with impaired hepatic function. And such lactic acidosis may be encountered in diabetic patients with excessive alcohol intake, or sometimes with concomitant use of radiographic contrast. The third type of antidiabetic agents is what is called thiazolidinediones. And the mechanism of action of these antidiabetic agents is to reduce insulin resistance and improve the peripheral action of insulin. Examples: rosiglutazone, pioglitazone. Sometimes we may have a combination of thiazolidinediones with insulin. And whenever we have such combination, the dose of insulin can be reduced or even can be omitted. Also, rosiglitazone may be given alone or in combination with metformin or sulfonylureas. The fourth type of antidiabetic agent is the group of meglitinides. An example of these meglitinides are ripaglinide and netiglinide. The mechanism of action of these meglitinides is similar to that of sulfonylureas, but they have rapid onset and short duration of action. And because of this, they can suppress postprandial hyperglycemia. Such antidiabetic agents, the meglitinides, should be taken with meals and omitted in the absence of a meal. And this feature permits flexibility of the lifestyle. If the patient takes meal, he can take this meglitinides. Otherwise, he may stop it. The fifth important type or group of antidiabetic agents is the group of incretin mimetics. The mechanism of these antidiabetic agents is to slow the breakdown of incretin, which is the glucagon-like peptide 1. And this is usually by the inhibition of the enzymes concerned with the degradation of this glucagon-like peptide 1. And because of inhibition of degradation of incretin, there will be more insulin secretion and for longer duration of or period of time. Now, how can glucagon-like peptide 1 regulate blood glucose? Glucagon-like peptide 1 regulates blood glucose through several mechanisms. The first one is by enhancing glucose-dependent pancreatic beta cell insulin secretion. Also, glucagon-like peptide 1 can increase or promote insulin-mediated tissue glucose uptake. Glucagon-like peptide 1 can inhibit glucagon secretion and in doing so prevent postprandial hyperglycemia. Glucagon-like peptide 1 can restore the first phase insulin release and increase the second phase insulin secretion. Also, it delays gastric emptying, it depresses appetite, and increases satiety, resulting in reduced food intake with weight loss. Examples for incretin mimetics: we have the sitagliptin, we have the sexagliptin, and linagliptin. Some facts about these incretin mimetics. Number 1, they may be taken once a day for type 2 diabetes mellitus. Often they can be used in combination with metformin. They have little side effects and don't promote weight gain, as we have said. And an important point here that whenever we have patients with renal disease, the dose of this incretin mimetic should be decreased. This table is very important. Such table shows you the different effects of anti-diabetic agents used in the treatment of type 2 diabetes mellitus. And we have here many anti-diabetic agents with different effects on different parameters. In the first column we have insulin. In the second column we have sulfonylureas and meglitinides. In the third column we have the metformin. In the fourth column we have acarbose. In the fifth column we have thiazolidinediones. And the last column is concerned with incretin-based therapies. And here you can see the comparison between the effects of these different anti-diabetic agents on different metabolic events. Insulin, sulfonylureas, metformin, thiazolidinediones, incretin-based therapies, all these can reduce plasma glycemia, while acarbose has very slight effect on plasma glycemia. All these anti-diabetic agents can reduce postprandial glycemia. Regarding their effects on insulin level, insulin, sulfonylureas, and meglitinides, incretin-based medicines all can raise plasma insulin, while metformin, acarbose, thiazolidinediones have nothing to do to increase plasma insulin. They don't cause an increase in the plasma insulin. Regarding their effects on the body weight, insulin, sulfonylureas, and meglitinides, thiazolidinediones can increase body weight, while metformin, acarbose, incretin-based therapies will not increase body weight. Regarding the effects of these anti-diabetic agents on the lipid profile, insulin and incretin-based therapies can improve lipid profile. Sulfonylureas and meglitinides have no effect on lipid profile. They don't improve lipid profile, while there is a slight effects of metformin and acarbose in this respect. Thiazolidinediones have a variable effect on lipid profile. Some of them may improve, others are not. With respect to the risk of hypoglycemia, such risk is there with insulin. It is it might be expected with sulfonylureas and meglitinides, but not in metformin, acarbose, thiazolidinediones, and incretin-based therapies. And the last but not the least is tolerability. Insulin and sulfonylureas and meglitinides are well tolerated. There is good tolerance with these antidiabetic agents, while metformin, acarbose, and incretin-based therapies shows moderate tolerability, and thiazolidinediones show good tolerability. So this is very important to know about such comparison, or to know such comparison between different antidiabetic agents and their metabolic effect. Here, I just want you to be familiar with these new antidiabetic agents. Somebody may call it novel antidiabetic agents. In the first instance, we have a new incretin-based treatments. Under this, or within this group, we may have the exenatide injection. And such exenatide injection is injected twice a day at mealtime for those with type 2 diabetes mellitus with uncontrolled blood sugar by oral medicines. The mechanism of action is to stimulate insulin secretion and slow stomach emptying. In this group also we may have the extended release of exenatide. It is given once a week, also through injection or by injection. The third type, which becomes in use these days, is the liraglutide. It is called Victoza. Such Victoza is injected in the same day once a day. Another new antidiabetic agent is sodium glucose cotransporter 2 inhibitor. The mechanism of action of this drug, antidiabetic drug, is via inhibition of renal glucose reabsorption. So such a drug will increase glucose loss in urine. An example for that, canagliflozin and dapagliflozin. Such a drug is not used commonly because of its side effects. Another new antidiabetic agent is amylin mimetic or amylin mimetics group. And before we know this type of antidiabetic, we should review or refresh our memory about amylin. What is amylin? Amylin is a hormone synthesized in the pancreas, beta cell, and stored with insulin. The main effects of amylin are first, inhibition of postprandial glucagon secretion, so the patient will have no postprandial hyperglycemia. Second, amylin mimetics delay gastric emptying and carbohydrate absorption. And third, they induce early satiety. Keep in your mind that among diabetic patients, there are other measures in the treatment of this disease, apart from the measures that we have mentioned. Among these measures are aspirin therapy, and this may be considered when there is no contraindication for its use. Hydroxymethylglutaryl coenzyme A reductase inhibitors, in other words, the statins, are highly effective in management of diabetic dyslipidemia. Fibrates may be required for lowering of triglycerides. Niacin may be of benefit to increase or elevate the level of high density lipoprotein. And among diabetic patients, whenever we have hypertension, the blood pressure control should be recommended. Don't forget the change in the lifestyle or the changes of lifestyle in diabetic patients. And these include decrease of weight, to stop smoking, to practice exercises, and so on. Thank you very much.